Health Education Lecture Series. All the listeners of Health Education Lecture Series, I'm your host, Gurdeep Singh Sandhu, homeopathic consultant. My clinic address is 7021 Village Parkway, Dublin, California 94568. My phone number is 408 687 1899. And we are discussing in these lectures how the life was created from life. And in this lecture series, we have passed a long way since the fertilization of the ovum. And since the fertilization of the ovum, when the fertilized ovum was settled inside the mother's womb, and it has gone through changes, different changes to develop an embryo. And then what are the organs were new established over there, and how they protected and they served this new embryo develop into fetus. And ultimately this fetus was developed and retained inside the mother's womb until 280 days. And after the 280 days, a natural process starts, which is known as labor. And that labor is recognized by the name of labor pains. And we have already discussed about that one, what this labor pain is, why it starts. So we have discussed all about the labor pains and why these labor pains starts, what are the reasons behind that, what are the hormones which are acting to start the labor pains. And during the labor pain, what are the conditions, changes which takes place in mother's genital organs. All those things we have discussed systematically one by one. And the initial characterization of the pain, what is the characteristic of the labor pain, because there are many more other pains which are in the abdominal area, in the organs of the abdominal areas, but they have their different codes, they have their different characteristics, and they have their different route to run as a pain. But whereas this labor pain, it has its own course, its own route, and its own characteristics, which we have already described. And all these things we have divided into three different parts. The first part was the first stage of labor, and the first stage of labor, we have discussed about how it starts, what are the initial things we have to do, how to manage the first stage of labor. And before the start of actual labor, what we have to do, if it's a due time for the delivery, then what we have to do, all those things has been discussed in this course. And ultimately we are yesterday our Punjabi lecture was how to discuss about the second stage. The second stage starts from the full dilatation of the female genital organs, the uterine organs, and and the second stage starts from the full dilatation of the cervix, means the orifice or the pathway of the female uterus from where the fetus has to come out, and that is normally measured about 10 centimeter. And that 10 centimeter diameter is presumed as if the diameter of the head of the fetus at the time of full pregnancy at the time of delivery. There are some other conditions with which this head may be larger than the normal, or there are some other conditions by which head cannot pass from the this normal pathway. There is a disproportion of the pelvic area, and there is a constriction or non-dilatations of the mother's uterus, cervical area, and even there are some other complications, some of the other things which are coming along with the fetus at that time that may cause some problems in that way. So we have discussed all those things systematically, and today our lecture will be in English lecture, so that those people who do not understand properly the English and the Hindi media, they can understand what I am saying and what is the nature's procedure for the delivery of the fetus. So first thing we have discussed about that the second stage of labor starts from the full dilatation of the cervix up to the you can say expulsion of the baby. Expulsion of the baby uh, is not only a simple that the baby has come out. It has with many more other complications, and we should know about the management of the second stage. So the area, first of all, we told you the time period of the second stage is from 1 to 3 hours, mostly in the nulliparous, those who are giving first time birth to the child, nulliparous uterus. Okay, nulliparous girls, the first delivery, that second stage, because the first stage we have already told you about 14 to 16 hours it may take if it is not complicated, maybe shorter, maybe longer. But if it's longer than that, then we must think about what are the causes which can delay the process of first stage of labor, or to complete the first stage of labor and bring it to the full dilatation. In this way, the second stage we are discussing now has time period normally from 1 hour to 3 hours in nulliparous. And in multigravida, multiparous, this is half hour to normally 1 hour. To half hour to 1 hour, it is in the multigravida or multipara females, because their organs are already dilated. There is already elasticity maintained in the mother's valves, so it is easy for the child after that to come out. If it is not complicated, if it's not complicated, so what may complicate at this stage, we have discussed about the first thing, there may be placenta previa, partial or complete. I have already told you about the placenta previa, that the placenta is the part which is regrow, which grows inside the mother's uterus from the inner layer of the uterus, that's the endometrium, and then it is known as decidua. And when the fertilized ovum is inserted in this endometrial layer, it forms a specific section that is known as placenta. And the placenta, the normal position of the placenta is in the upper section of the uterus. In the back side, in the right or left side, from which side, on the opposite side of the uterus, from where the from which side the fallopian tubes is delivering the ovum at this time. Suppose if the ovum is being delivered from the right side, it may be inserted on the same side, or on the left side. Or only basically the normally always it is inserted in the back wall, posterior wall of the uterus. But under some conditions, I have told you about the uterine shuffles. These are the normal movements of the uterus which starts at the puberty, and these are not normally recognized, but these are recognized with the painful menstruations and also at the time of delivery. And due to uterine shuffle, increased uterine shuffles, sometimes this fertilized ovum is not inserted in the upper portion of the uterus, upper segment, and it falls down. It falls down in the lower segment of the uterus, and sometimes it may be covering partially the cervical opening, where the body of the uterus is connected with the cervix. that is the inner organ, inner orifice. It may be inserted and covering the partial that openings, or sometimes it may be inserted at a position where it covers the whole area. It covers the whole area of that orifice, and there is no other holes remaining. So at the time of delivery, we are, as we are discussing about the second stage of labor, because there is the full dilatation that we can see. Cervix is taken up off and it is full dilated, 10 centimeter diameter, that we presume that the head of the fetus will be about this size. And also we have assured that the pelvimetry of the female, the distance from bones to bone, is also maintained in a normal scale and normal standard. Even then, sometimes there are some complications because of the placenta previa. So if the placenta previa is partial and it is covering some part of the orifice from where the fetus head has to pass down one, it may cause some problems. And we have to diagnose the condition beforehand, because it is taking at least some part, some inches, centimeter part of the orifice, and it will create difficulty. Second thing is, with the extreme intensity of the pain, this placenta previa may rupture. And if it is, because it's a soft pulp type of mass, and if it is ruptured at that time, there may be a gush of blood, excessive bleeding at that time, even before the delivery of the child. And that's also a complicated thing. In that way, we have to manage this second stage, and we have to verify the things, that it's only the head which is coming out, or it is only the part of the baby. Either if it's a breech presentation or whatever the presentation baby is coming out, is it the same part or something else is coming with that one? So that we can diagnose when the you can four water bag is coming up at the intensity of the pain, and when we palpate that thing, we can presume on the circumferences that it is only the head, or it is only the other parts of the fetus, none other, the like placenta previa or anything. Then we can make sure that yes, the delivery of the fetus may take within half an hour to 1 hour maximum. And in case if the placenta previa is complete, we are talking about the management of the second stage. If the placenta previa is complete, it means it is covering the internal whole, full whole of the cervix, uteri. And but during the pregnancy period, it means in spite of floating downward from the placenta, the fetus is floating upward and the placenta is downward. Under those conditions, basically, we diagnose. Now there are many more other means that we can judge all these things before the labor times, and we can check the position of the fetus, that how the fetus has come up. If there is a placenta previa, what is the position in the uterus of the fetus? So all these things we can diagnose beforehand, so that at the time of delivery there should not be any complications. But it is a complication. It is a complication that if the placenta previa is a complete, then we cannot expect that the fetus will come up first. No. First of all, the placenta previa will come up. And when there is one term used, show. What is showing up? After the four water bag, when we press that four water bags, you feel that bones of the heads we can palpate. We can recognize the head size. But if the placenta previa is coming up first, then the baby, then under those conditions, in the four water bag, you will see a soft, you can realize by your fingers, a soft mass is coming up, and that is pulsating. That soft mass is coming just within that four water bag, and it is pulsating. That indicates that the placenta previa is coming up first. Under those conditions, a serious condition may happen that the placenta previa will come first, and then it has been disconnected from the mother, means that the now for the new food source and the new oxygen source has been disconnected. Mother was supplying up to end. Mother was supplying the oxygen and food to the baby through the placenta as well as the umbilical cord. But now the condition is that the placenta is coming first. Under those conditions, with the extreme of the pain, it is detached. And when it is detached, it means there is a bleeding internal as well as external, because it is coming up first. And the raw surface of the placenta previa, or you can say the maternal surface, because placenta previa has two surfaces. One is the interior surface that is known as towards the fetus, that is the interior surface that is bluish color, and the posterior surface that is reddish in color, that is the maternal surface. Fetal and maternal, you can say anterior or posterior, you can say whatever you want to name it. But this is the condition of the placenta previa. And at that time, when there is a raw surface from where this placenta has been detached, it may ooze a heavy bleeding at that time, especially when there is a contraction of the uterus from the backsides. And now the fresh blood is not supplied to the fetus, oxygen is not supplied to the fetus, and we don't know how long it will take the fetus to come out after the placenta previa has been delivered. Placenta previa was coming first, and it has been delivered first, and there is a bleeding. There is excess bleeding coming up with the placenta as well as from the raw surface inside the uterus. And sometimes there are incidences that the forewater bag is ruptured, water has come out, and this bleeding may go inside and into the mouth of the fetus. That again may create aspiratory type of things, complications, which is more complication for the fetus. And we have to take care of all these things at that time, so that forewater bag should not be ruptured before that head is delivered, so that we can take care of the mouth of the fetus. And then after that, we have to take care of this heavy bleeding which is coming up with every gush, every extreme of the pain. We have to take care of these things. Under some conditions, if there is a heavy bleeding, even it may cause unconsciousness or something to the mother as well. And also, when the oxygen is not supplied, the food is not supplied, and the baby is not yet delivered, but there is no source of extra feeding at this time, and if it's taking long time, then sometimes the stillbirth may happen. Child may die in the mother's womb before it is delivered or at the time of delivery. So at that time, the management says that we must expel the baby by all means immediately after the placenta has come out, so that in a short while this baby should be supplied with the food and oxygen. And after that, it is instructed also that when you have to cut the cord from the baby, you have to squeeze the blood. We have to squeeze the venous blood from the placenta towards the fetus. Why? As you know, that when the placenta was formed in the initial stage, I told you, in the umbilical cord is formed, and in the umbilical cord there is a one vein and two arteries. It is different from us, different from our human circulation totally different in the fetus. So the fresh blood is supplied by the vein, and deoxygenated blood is coming from the fetus to the mother back is by the arteries. So arteries are two, vein is one. So we have to recognize the veins, blue in color, and the arteries. These are two small veins, and we have to suffuse the blood towards the fetus so that if he is devoid of food and oxygen for a short time, it should be compensated. Then after that, it is advised that you have to cut. First of all, you have to clean up the air passages. First thing, after the delivery of the baby, you have to clean the air passages of the fetus so that it can breathe normally. It can breathe normally, or the environmental air should go inside. And here I have already told you that there is a environmental pressure on us every time in our environment, 480 millimeter of mercury. That's the normal pressure of our environment. Always we are bearing it and living with that. That has become normal conditions. When the baby was in the mother's womb, this pressure was taken out from the baby and was covered by the uterine wall as well as the abdominal wall of the mother. But as long as it comes out from the mother's womb, this pressure child has to bear himself. And if he has to bear it himself, immediately with this pressure, chest is squeezed, and with the secondary action, it dilates. When it is squeezed, means whatever is inside the bronchus, whatever in the air passages as a whole, you can say, whatever is in the air passages as a whole, it comes out, and it gives way to environmental air to go inside the fetus. So this process start, and it starts with the cry of the fetus. This happens. Okay. So under those conditions, when the head is delivered, we have to take care of the air passages. Second, we have to safeguard the eyes of the fetus from the infection. Sometimes the mothers may have any infection, urinary infection, or any other type of infection, Licoria type of things, a bacterial type of things, whatever. May or may not be. But even then, it is advised that if it is suspected, then you have to clean the eyes of the fetus so that any infection outwardly from the female genital organs or from the mother should not cause any problem to the fetal eye or any other organs. So it is advised that clean the eyes from middle side to the outer side. It means from the nose side to the outer sides. Medial canthus is nose, outer canthus is the outer side. So towards the ears, from nose to ear, we have to clean the eyes, and also we have to take care of the respiratory organs so that child should start a normal breathing after being separated from the mother. Under those conditions, there is one another condition, to cut the cord. To cut the cord, this is in a medical term is known as it's a religious hours, it's a religious time, that now this child will be separated from the mother forever. Forever, it's going to be separated. Previously, mother was doing everything for the child, feeding, oxygen, everything, secretion, excretion, whatever is done by our body for each and every system. As you know, there are 9 systems working inside the body which are creating a normal life. All those functions were carried out by the mother and by the placenta and umbilical cord. But now, all these functions are to be carried out by the child, by the fetus itself. And in that way, we are providing, we are at the juncture of that hour that we have to cut the cord. And especially If the placenta is still in, it was in a normal condition, that comes out after the comes later, before the baby comes out, that's okay. But now we are discussing the complications. With the complication of placenta previa, the placenta comes first. Even then even then we have to cut this one, so that we can feed separately child with the outside meal, that is the food, milk, whatever. So what we have to do, we have to clamp the umbilical cord. After squeezing it towards the child, we have to clamp the umbilical cord in two spaces. One space 2 inches away from the fetus, one space 1 inches away from the fetus, and then in between the middle of these two clamps, you have to cut it, clean it with antiseptic lotions and all that, and tie it, so that there should not be chances of any leakage, because this umbilical cord is pulsating at that time, and sometimes due to the pulsation, sometimes the knot becomes loose. So make sure that your knot should not become loose even with the pulsating of the umbilical cord. And there should not be any other complications with the umbilical bleeding later on. So you have to make sure antiseptic bandage should be applied on that one, and cover that area after cleaning in the baby. And then hand over the baby to the assistant to give him a shower, lukewarm water shower, that the child can bear it. So in this way, now that the responsibility that the assistant will take care of the respirations and also the umbilical cord, and then give him the clothings. Now come to the other side of the female, mother side. So when child has been taken out in a normal condition, still placenta is inside in the normal positions. If the placenta is attached at the upper portion, upper segment of the uterus, under those conditions, placenta has to come up. And the period for the placenta, because the second stage is from the full dilatation to the expulsion of the baby. It means placenta is still there. So ultimately, it takes about 5 minutes to 30 minutes maximum. As long as this placenta will retain inside the mother's womb, it may create problem. It may attract infection, outside infection to inside to the mothers. It may cause complications for the life of the mother. That's why it is advised that the cut section of the umbilical cord should be saved separately. Also, antiseptic. All measures should be taken so that antiseptically no infection from the outside should go in to harm the mother at that time. And we should wait to deliver the placenta. We should wait to deliver the placenta. And sometimes the placenta is fixed hard, it's not coming with the normal, because sometimes after the delivery of the patient, there is the inertia of the uterus. Inertia of the uterus means the uterus now become weak, and it is not contracting forcibly, relaxing forcibly, contracting forcibly, then the placenta is not attached. Then you have to put some traction, light traction to the umbilical cord, so that you can detach by manually, you can detach the placenta from inside. And normally in the nature's process, within 5 minutes to maximum 30 minutes, it has to come up. And otherwise, if it takes long time, you have to use the manual means to bring it out, so that if it will remain a long time in the uterus, after that, after being cut the umbilical cord, it may cause any sepsis type of condition, infection type of the condition through the mother. To save those things, you must be acknowledgeable to save the infection of the mothers after the delivery of the fetus. So you have to clean the cut end as well, then put some directions so that placenta can come up. Some There are other conditions that you can grip, abdominal grip of the fundus of the uterus. That's very soft area at that time, and you can palpate the fundus of the uterus, pull it, throw it, pull it, throw it. And when you will grip, throw it, ultimately the placenta will be detached and it will come out. So these are the procedures normally adopted in the clinics when the other means are not available at that time, and mostly it comes out. Very rarely, some other conditions may come up, and the placenta previa is late because of some inertia of the uterus. But you can massage the abdomen, you can grip the uterus, you can relax the uterus, you can grip the uterus continuously. If you will do it a few times, placenta will be detached and it will come out. So now we have to use the antiseptic measures so that mother should be saved from any type of infection which may come up after the delivery of the child as well as the delivery of the fetus. To save those things, we must be technically trained about that one. On the other hand, the fetus has been delivered, placenta has been delivered. We have to check the placenta. At this time, our position is to check the placenta. First of all, we have already checked the fetus. The air passages, we have checked it. We have checked about the urinary passages as well. We have cleaned the nose and throat and mouth, all that one. That we have, if possible, we need the suction to suck the excess flame from the or cheesy matter from the bronchus and from the lungs, or also to supply the oxygen. So all these measures should be taken until the baby becomes red, okay, pinkish red, means the oxygen has been supplied. And then that can be wrapped up and closed. After that, one part of the delivery is over. The second part of the delivery is the complications under these conditions. Antiseptic measures that you know of, we have to do the antiseptic measures. And after that, if there is excessive bleeding, there may be, we have to check the tear, vaginal tear or the perineal tear. Perineum is a portion between the vaginal lower end of the vagina to the anus. In between anus and also the vagina, there is a portion which is known as perineum. And perineum is about score type, four-sided type of area. Underneath, many of the nerves which control the functioning of the genital organs pass on. That the coccygeal nerves pass from that one to control the prostate in the males and uterus and in the females and all that. These are passing from there one. So sometimes there is a, if it is a large head has been forcibly delivered, sometimes there may be a rupture in the perineal area that you have to take care of. Or if in case you, by for your facility, have done the episiotomy, then you have to stitch that area and take care of that wound. Sometimes there is a forcible delivery of the head and the cervix of the uterus is ruptured, that you have to take care of that one. And after that, if there is a gush of blood still coming up, then you have to massage the abdomen. You have to massage the basically uterus through the abdomen so that the inertia of the uterus, weakness of the uterus be covered, and there should be a normal contraction of the uterus to control the internal bleeding, and it controls likewise. And under case, if all the wounds, if ever there be, has been caused by the passages of the fetus, or you have made it yourself to facilitate the delivery of the head of or part of the fetus, then you have to take care of those wounds, okay, so that there should not be any harm to the baby and also to the mother later on. So you have to take care of the mother, his blood pressure, respiration rate, all these things. And also you have to check the baby. There are some external you can say anomalies which we have to check at that time. I have already told you about that the most of the organs inside our body are made in parts, and then they join each other and form a complete organ, just like the intestines. The different portion of the intestines are formed separately, and then ultimately they join and form a complete intestine. The same way, vertebral column. All the vertebrae are composed separately, and ultimately they join. All these things, it's for not only one organ, for the many organs. In the same way, if the intestines has not yet joined because of the underdevelopment under some conditions, meconium will not come out. Meconium in the first stool of the child will not come out. That you have to take care within 2 hours of the delivery. Sometimes the prepuce, the outer covering of the glans penis in case of males, has covered the whole area of glans in general, but it is joined. It is not separate. It's not making any hole in front. That is known as phimosis, which is normally completed and make a hole at the last months of the pregnancy. Just like the testis comes out from the abdominal area. If a male child is there in the side, the abdominal testicles remains inside the abdomen, and at the 7th or 8th month, these testicles travels through the inguinal canal into the scrotum, and we have to check that whether the testicle balls are in the scrotum or not. And then we have to check the phimosis, that the prepuce, if the prepuce is joint in front or not. Otherwise, child will not be able to urinate, and then he will cry with the pain. Or sometimes a bubble comes out in front of the prepuce because urine is full. Because urine from the kidney side, the urine is already filtered. It's coming up into the bladder. When it comes up into the bladder has its capacity. And with that capacity, it's a small capacity, less than 30 ml. Then that blood, when the bladder has 30 ml capacity, then ultimately there is a urge. We adult feel urge, but the child cannot express that. But it's automatically that the drops of the urine comes out, but there is no hole in that, in the prepuce, in the inner linings of the prepuce. They are united with completely. Then you make the whole. Just like some people are talking about just explaining the things that in the females there is a hymen, but naturally hymen has moon type 2 or 3 openings. Sometimes one opening, sometimes 2 or 3 openings, one big opening, 2 small openings. In this way, sometimes the hormone has many tiny openings, or sometimes the hymen in the female is not having a single opening. Under those conditions, it is not judged. It is judged when the girls comes to the puberty age and menstruating age, and she menstruates, she feels pain, but bulging out pressure inside the vagina, but no bleeding. Every menstrual niches, she feels pain, and there is a heaviness in the lower vaginal areas, but no bleeding, because hymen is complete. And if the hymen is complete, blood will not come up. This condition is known as cryptomanoria. And under some conditions, just like people say that during first intercourse, or sometimes by cycling, or sometimes by doing excessive exercise, this hymen is ruptured. Yes, it may be, but mostly the hymen has one or two openings in that, moon type openings. But similarly, just like the phimosis, I am telling you, in the male childs, the phimosis is the upper covering of the glans penis is complete. It's not having any opening, and the urine is not coming up from that in the male, because you know that the semen and everything, urine is coming from the same opening. So at this time, it is the immediately we notice that the child is not urinating, and in the front portion of the uh, penis, it it comes out just like a bubble. It comes out like a bubble, and the child crying. It's not going back that. And in case of females, I can just would like to that's out of the way, that comes in the gynecological. But even then, I can tell you, if there is a cryptomenoria, menstrual bleeding is coming up from the uterus, that is the normal procedure of the hormones. But it comes out into the vaginal area, and girls are unmarried girls with no sexual intercourse, no this type of exercise which can rupture the hymen. Under those conditions, the vaginal area is filled with that bleeding which is coming from the uterus. And regularly, a dull type of pain, continuously heaviness feeling in the vaginal area, girls feel continuously. And ultimately, that blood is again sucked up by the mucous membranes of the vaginal area. And again, at the next menstrual cycle, again the same thing happens, and that comes out. And parents think ultimately parents think that my girl is now all the girls at 11 or 12 years age, they menstruate, but my girl is 16 years age, even 17 years of age, or even 15 years of age, but she is not menstruating, but she has pain at every menstrual nisus. She has pain but no menses. Then they consult the doctor. When they consult the doctor, then they find out that the hymen is intact hymen, with no hole, with no single hole. That is why she's feeling pain at every menstrual nisus, and after that, that blood is being sucked again back into the system, and every month it's happening. And then surgical intervention is required. Sometimes it happens that the elasticity of the hymen is tight. You can say it is a strictly tight hymen, and it is not ruptured even sometimes with one, two, three, four sexual intercourses. And sometimes it has created a doubt in the females, that they feel pain during sexual intercourse, but there is no bleeding. And they doubt about this one, and ultimately results that when you consult the doctor, it says that it's a cryptomenoria. She is having intact hymen, hard contact hymen, which is not ruptured during menstruation, or which is not ruptured during intercourse, which is not ruptured by any exercise whatsoever it is. And then we need the surgical interventions for these type of conditions. So that was a separate chapter. But we are discussing about the second stage of the labor. And so far, at the second stage of the labor, as we describe, I can just within a few words, I will describe it, because now I think the Hindi program I will not take up. I will take up just the English program, and tomorrow we will take up the Hindi program as well. And second stage we are discussing, that second stage starts from the full dilatation of the uterus, that is 10 centimeter in diameter, and with the normal pelvimetry, which can allow the head to pass from the mother's uterus into the vaginal areas and also outside. So this is what we have to make sure before the delivery is going on. And at the second stage, we must be aware of that if there be any complications. And the complications we have already discussed about the uh, uh, placenta previa. Clearly, placenta previa or partial placenta previa. Complete placenta previa and partial placenta previa may be a big complication at the second stage of the labor. And we should make sure before the delivery starts, even even if the first stage of the labor is going on at that time, because nowadays we have devices, and ladies are going in the antenatal clinics, and in the antenatal clinics they check it, what's the position of the placenta, what's the position of the fetus. And under these conditions we can judge clearly that whether the fetus is hanging down or fetus is floating upward in the uterus. Means if it's hanging down, means the placenta is attached at the upper portion of the uterus. If it's floating upward and the umbilical cord is showing downward, it indicates that the placenta is downward. And the downward condition is also, is it partial or is it a complete? And we have already discussed about the partial and complete conditions of the placenta previa, and complications coming with that one during the labor periods. But nowadays peoples are of these separate type of different type of mentality. They do not take any risk under these conditions, and they go for surgery. They go for cesarean sections, and they do not take any risk that if there be placenta previa partial or placenta previa complete, why to go for the complications? Why to wait for that one? They go for the surgery. Okay, but even then, when it was not possible, when it was not possible, at that time we were facing all these things. We were facing all these things, that if this type of condition happened, that's a natural thing. That's a natural thing. That's because of the hormones things. That is because of the uterine shuffle movements at the time of pregnancy starts in the uterus, comes into the uterus, and it is slipping down and slipping down in the lower segment of the uterus. So this was happening even in the earliest years, and it is also happening nowadays, because this factor is concerned with the uterine shuffle movements in the uterus at the time of pregnancy. So it may happen, it was happening, but if it is happening and the pregnancy is developing, there's no harm in developing the pregnancy. But sometimes, if the placenta previa is downward, a partial or complete placenta previa, the whole year, the period of the pregnancy, ladies feels heaviness and pressure downward, and thinks sometimes there is a recurrent bleeding from the complete placenta previa. Recurrent bleeding from the complete placenta previa, that may complicate the conditions that the child is not fully developed, because he is not getting the full proper food from the mother, and then that is why there is a bleeding, and that bleeding is causing complication in the development of the fetus. So under those conditions, we have to take early measures. If we diagnose that the placenta previa is a condition of the pregnancy, and there is a bleeding even before full term, the time is not viable at this time, means it's not 280 days of the pregnancy, and then if it's a recurrent bleeding of that one. But first thing we have to watch, we have already discussed many a times, our first and foremost duty is for the passenger. So who is the passenger? The fetus. We have to take care of the fetus, that by all means we have to take care his survival. And under those conditions, if there is a heavy bleeding and coming regular return bleeding, and the child is becoming weak and weak, sometimes the doctor advises early termination of the pregnancy, MTP, medical termination of pregnancy. Mostly, the MTP term is used for the early abortion type of things or early miscarriages type of things. But even then, the child survives. But if there is this kind of conditions of placenta previa and it's causing bleeding even on the after fourth or fifth month of the pregnancy, and it's a regular type of bleeding, then child will not grow normally, and it will cause health hazards for the mother as well as the child. Under those conditions, some doctors advises MTP, medical termination of pregnancy, so that we can save both child and the mother. Otherwise, there are chances of sepsis, chances of sepsis to the mother, chances of sepsis to the fetus as well, or there are some other complications which may complicate the pregnancy. But if there is no bleeding, maybe the placenta previa is partial or complete, whatever, means the outer opening of the uterus to the cervix is packed with mucus plugs normally, and it is not opening, and the placenta where it is attached to the mother's inner linings of the uterus is not detached. If it's not detached, even then, under these conditions, the lady continuously feels pressure, always feels pressure downward throughout the pregnancy, heavy. And there is you can say, the tilted gait. When she walks around, you can feel that she is not walking normally, she is not walking straight, because always there is a pressure inside the womb, and she is not walking straight according to the other normal positions. Okay, this indicates to the persons who can judge that lady pregnant with the placenta previa, yeah, she is not having normal. Even ladies with heavy hemorrhoidal vessels, the, the hemorrhoidal vessel will supply the rectum, will supply the blood to the rectum, and it takes blood from the rectum to upward. That has a separate system we have already discussed many times, but even then, when again time will come, I will describe that. That hemorrhoidal vessel is converted into three branches in the rectum, and sometimes they are bulged out with full of blood. The blood is not going back normally because of the pressure or swelling of the or excessive stool inside the rectum, and they are full of blood and they are tight as needles. They feel pricking as needles. Under those conditions, when the lady walks with hemorrhoidal conditions, that has also a same type of gait, same type of walking by their wide legs. The same thing happens in the pregnancy times. There is otherwise the whole weight is lifted by the muscles of the uterus, and they are not putting any pressure on the abdomen, the lower portion of the abdomens. Weight is carried out with that water amniotic fluid as well as the muscles of the uterus. But when there is a placenta previa in the lower portion, the pressure comes downward. And when the pressure comes downward, it's not a one time condition. He has to pass through this period, these things, throughout the pregnancy period, that is 280 days. And sometimes with regular pressure downward, pregnant delivery starts early. Delivery starts early because the regular pressure causes the dilatation of the cervix. And sometimes, if it's too early, just like a 6 month of the pregnancy, though we have instances that the child survives even after 180 days of pregnancy, but even then doctor try that it should not be delivered, it should not be delivered more than 210 days. This is what the expectations are, so that all the organs has been formed, all the organs has been working normally in the mother's verbs, then we can advise the delivery of the baby that it can survive without the mother as well, outside of that one. But under those conditions, sometimes the regular pressure because of the placenta previa is putting pressure and making dilatation of the cervix. early, early than the due date of pregnancy. So under those conditions, sometimes some doctor advises stitching of the cervix. They stitch it, and sometimes the doctor advises the lady to complete bed rest with raised foot end, raised hip area. Raised foot end means the bottom, the platform of the bed should be raised at least 10, 12 inches, so that this pressure which is exerting continuously on the cervix should be released, should be in rest conditions, and ultimately the cervix should not be open wide to allow the pregnancy, allow the delivery to come early. So all these measures are generally there. There are some other means. At my times when I was a student in medical course, at that time there was a ring pressure, which is normally used for the prolapses of the uterus. People use a ring pressure, a type of a rubber ring which is adjusted inside the cervix, and then it is fixed with the pelvic brim, ischium, both sides, pubic, upside. It is fixed so that the uterus will not come down. And same type procedures is sometimes adopted if it is not due date, if the pains are starting early because of the placenta previa. Under these conditions, people used to give fuller time to the fetus to develop inside mother's womb, because the deficiency which remained at that time are not compensated. It's very, you can say, unfortunate that the deficiencies which are not covered in mother's womb, they are not easily covered even after the birth of the child, even with full time diet and all precautions are taken. Even then those deficiencies remains. That is why it is advised that the child should remain maximum period in mother's womb, and the total period is 280 days, but maximum period means it should be not less than 210 days. And after that, if it's possible, if it's inevitable, means we cannot avoid that. If it's inevitable, yes, we can go for delivery for that one. But if the mothers bear that one, and if a mother is understanding the conditions, that as long as your child will remain inside your uterus and you feed her through the placenta, he will become healthy. But if it comes out, that deficiency will not be compensated even with better diet, better management, everything. It has been learned nowadays from the many cases which are delivered early, which are delivered early than their due date of that ones. So today we have just covered the English lecture of the second stage, and tomorrow we will in Hindi lectures, we will deliver all these things in Hindi. Plus, tomorrow, our lecture will cover the third stage of labor. Management, basically, the management of third stage of labor. Because the third stage starts from after the delivery of the baby. And the delivery of the placenta comes in the third stage. Well, delivery of the membranes and the umbilical cord comes after that. So that will be taken up into the third stage, and we will discuss it tomorrow. First lecture will start at 5 in Punjabi with the Radio Pravaz, and after that, because today I could not take up the Hindi lectures, and then this Hindi lecture I will start tomorrow and will cover both portions, the management of second stage and management of the third stage, tomorrow at the same time. It may take a little longer times, but even then I will try into the Hindi. First lecture will be in Punjabi from 5 to 5:30. Second lecture will be 5:30 onward up to 6:30, so that I can cover in Hindi the second stage and also the third stage of the labor. God bless you all. I am your host, Gurdeep Singh Sandhu, homeopathic consultant. My clinic address is 7021 Village Parkway, Dublin, California 94568. My phone number is 408-687-1899. Email address homeomedicine, HOMEOMEDICINE @yahoo.com. Anytime when you are tired of any treatment for any disease and any age, you can call me for second opinion, and you can get benefited from my 51 years of experience of practicing homeopathic and ayurvedic medicines, and also experience as teaching in medical colleges for about 26 years continuously. So you can get benefited from this knowledge. And if ever even you are being treated by other physicians, it's okay. If you want to take a second opinion about your disease, even then you can call me at 408-687-1899. Email address homeomedicine, HOMEOMEDICINE @yahoo.com. So you can call me anytime by email or by phone and get your answer for your questions concerning to the health. Rabrakha, God bless you. We'll see you tomorrow.